Thank you so much for having me at this conference. I think the CFRI conference is such a great opportunity that I love that it spans kind of all aspects of CF care, from the wonderful basic science, translational science talk we just had to discussions about mental health yesterday. I'm hoping that my talk kind of also bridges some of actually adds to the mental health discussion we had yesterday and talks a bit more about how to help people have their best life. So no disclosures or conflicts of interest. So my goals for this talk are to increase your knowledge about the importance of sleep, to empower you, give you some tools and techniques aimed at improving sleep quality, and empower patients, and to bring up sleep concerns with providers during their clinic and hospital, and really convince everyone that a sleep assessment should be part of the CF standard of care plan. So first, we're going to start with understanding why sleep is important, discuss specific factors relevant to patients with CF, discuss the available information regarding CF and its effects on sleep, and review some common sleep disorders, and then even review some possible treatment strategies to optimize sleep, even during this current pandemic, which I know has probably affected everybody's sleep. So first, we used to think of sleep was just the absence of wakefulness, but pioneers like Dr. William Dement, pictured here, helped us to understand more. Dr. Dement actually recently passed away at the age of 91, and I will say loved his job and really helped us to understand more about why we sleep, the dangers of poor sleep, the benefits of good sleep. So why do we sleep? We think sleep is thought to be restorative. It helps build muscle and bone. It activates the immune system, consolidates learning and memories. Poor sleep, we know, I think we've all experienced what poor sleep feels like. You have a lower mood, there's lower learning, we have decreased immune system function, heart disease, hypertension. There's association even with diabetes, mental health issues, depression, anxiety, and overall poor health and quality of life. So newer studies are even associating poor sleep with increased depression and suicidality in young men. So I think this is a very important issue we should all take seriously. So sleep is a very dynamic process, physiologic processes under neurobiologic regulation. All stages of sleep are important. People always ask me, which stage of sleep do I need the most? I'm like, all of them. And the sleep stage distribution is modified by your age, your sleep history, your natural rhythm, circadian rhythm, which I'll talk about in a minute, and just your genetics and how disturbed your sleep is. So your sleep architecture, this refers to just kind of putting all the different stages together, like how they kind of all line out. So this is just showing you a little bit of an example that you have a type of sleep called rapid eye movement sleep. This is when most dreams occur. This is when your brain is very active, but your body is relatively paralyzed. Shallow sleep, it's like a transitional sleep. It's like you're moving from awake to sleep. It's very brief. N2 is called light sleep. So this is a sleep that it's pretty easy to wake you up. And then slow wave sleep. This is the nice restorative sleep. Those of you who have kids, this is the one that you can just pick up your child and carry them and they don't even wake up. So that's called slow wave sleep. All the different stages of sleep are important. Sleep, why is it a vulnerable time? So from a pulmonary perspective, your minute ventilation goes down. Your minute ventilation is how much air and gas is exchanged with each minute. So when you take a breath in, take a breath out, how much gas is actually exchanged. Your lung volume per breath goes down. Your upper airway resistance, that means how easily it is for air to pass through your upper airways, actually goes up. So it means it's a little harder for air to get in. And dream sleep, REM sleep, REM sleep, is when most of these things are most pronounced. So remember, you have that active brain, but your body is actually is in a paralyzed state, meaning it's not moving as efficiently. People always ask also, how much sleep should I get? What's a normal amount of sleep? So I just show this great infographic by the National Sleep Foundation. So I think the general trend of this is you need more sleep the younger you are, the less sleep the older you get. I show this because it's great because it shows a range. So for instance, an adult, 7 to 9 hours is usually generally recommended. There's some people who need a little bit less, some people who need a little bit more. Just as a fact, a lot of people say, oh, I only need 5 hours of sleep and I'm fine. There are short sleepers do exist. They're very rare. So generally when people say to me, oh, I can just sleep 5 hours a day and I'm good, I ask them, well, what do you do on vacations or weekends? I go, oh, I sleep for 14 hours. So that tells me you're not actually getting enough sleep. So I mentioned this, so you can look at the kind of the recommended average, think about how much sleep you get, and think, gosh, if I'm way outside of this average, why, what's going on? You know, something to just be explored. So what keeps most people from getting enough sleep? I think he is the quintessential human in this era that we are today. So electronics is one of the #1 things for adults and for teenagers and for kids. Work, sleep demands, stress, family, social demands, medical issues, et cetera, et cetera. Of course, with CF, there's also specific factors that are affecting sleep. So having a chronic cough, pain, frequent stooling, heartburn, abdominal discomfort, especially if you're getting your feeds throughout the night, medication side effects, and maybe you need some respiratory treatments throughout the night as well. When we look at studies with patients with CF, adults and children, we find that studies show 50% of patients with CF report disturbed sleep. Patients with CF are more likely to report daytime sleepiness. This frequency increases with severity of lung disease and for those waiting a transplant. Children and teenagers with CF are affected by insomnia and sleep disturbances at high numbers. I think I've seen some as quoted as high as 80%. More than 80% of children with CF report nocturnal coughing compared to less than 5% of children without CF. And we know that poor sleep contributes to decreased quality of life in patients with CF, so it's important to address it. There's a recent, a few studies that have just come out in the past couple of months, which has been really exciting, where they look at sleep disruption in both patients and caregivers. So this was mostly focused on pediatric patients, but it found that 40% of caregivers reported concerns for their child's sleep, and 29% of caregivers were concerned about their own sleep. When you had kids who were in the 6 to 12 age range, this was actually worse. The numbers jumped up to 44 and 55%. So it's not only that when your child has cystic fibrosis that it's affecting your child, it's also affecting the caregivers. And I think this can probably translate to our adult patients too. And they found that both patients and caregivers were getting insufficient sleep hours. And note, these were actually outside of pulmonary exacerbations. That's what they wanted to say. Even when the patient's relatively healthy, they're still having sleep disruption. So chronic pain, that's a big issue that's reported in most patients with CF, headaches, chest pain, abdominal pain, back pain. Most patients report they are self-managing their pain and may not report it to the provider. So I think it's just something for us as providers to really kind of ask about it and be aware and see how we can help. When I have a patient coming to my clinic to assess them for sleep, this is one of my, my most favorite tools. It's a sleep log. Basically, it's just a way to keep track of sleep-wake schedules and identify disruptors. This is just an example of what I use. There's nothing magical about this one. You can use a journal, a piece of paper, whatever you want. But I always tell my patients, really let's try to track and see what you're doing, because this is where you can start to see patterns emerging. You can get a sense of how many hours am I sleeping? When am I drinking that cup of coffee? Oh, it is just before I go to bed. Hey, you know, every time I take this medication, I have a harder time sleeping. So those kinds of things can come about when you track your sleep. Other ways to objectively measure sleep, there's something called an actigraphy. This is, I liken it to, it's really what Fitbit or those things are trying to mimic in a cheaper way. So an actigraphy can help determine regular sleep-wake patterns better than a sleep study. So you would wear it for every day for a week to 2 weeks, live your normal life, and it would actually measure light exposure, sleep, rest, all those things. And so when we actually looked at actigraphy studies with CF patients, we found that they had more sleep disturbance. Just to give you what we're looking at, so this is kind of what some of the devices look like. So pretty simple, not very attractive looking, but they work really well. And then here, this is an example of actually real patient's actigraphy. The blue highlights when this patient is sleeping. And all this is like yellow, and these squiggly lines look at light exposure. So you can see here, blue is when this patient was sleeping, and you can kind of see where there's a little bit of shifting on the weekends. It's supposed to be Friday, Saturday. You can see here on Sunday where the time is shorter. So this really helps us get a sense of what patients are doing. Another way to objectively measure your sleep quality is through a polysomnography. Or a sleep study. So this measures your breathing effort, breathing rate, oxygen level, carbon dioxide level, sleep architecture, and your limb movement. So this is the most comprehensive way to look at what one night's sleep looks like. Patients with CF generally have normal sleep architecture. Their brain can get into all the normal stages of sleep, unless they're having a pulmonary exacerbation. And that time, we usually see that there's more wakefulness, and decreased dream sleep or REM sleep during that time, really just because you have more sleep disruption. Other things that are kind of really important to measure or to keep track of when a patient's sleeping, especially with a patient with CF, is that you look for things like nocturnal hypercapnia. This is retention of carbon dioxide while sleeping. In general, we breathe in oxygen, we breathe out carbon dioxide. So patients with cystic fibrosis are at increased risk due to parenchymal lung disease, so meaning their lungs become less effective in gas exchange. So this is typically seen actually before daytime carbon dioxide retention. So it's actually an early detector of worsening lung disease. This can be diagnosed with a sleep study or even a blood gas. Another measure we look for is for nocturnal hypoxemia. So this is when you have low oxygen when sleeping. So patients with CF are at increased risk for the same reason as the other one, right? So you have parenchymal lung disease that affects gas exchange. This is also typically seen before daytime hypoxemia is noted. So you can do this with a sleep study, which offers a lot of detail, or a home oximetry study. And this is essentially an oximetry study is where you just have a very detailed pulse ox that records the oxygen levels throughout the night. In a recent study for children and teens, they demonstrated 29% of patients had nocturnal hypoxemia without any daytime hypoxemia. This is of course in a single center, but it was really, I mean, it was like a third of the patients. More time was spent, and it was also found that the more time spent with oxygen level less than 90%, that was associated with a decreased FEV1 and increased length of stay in the hospital during exacerbations. So even the subtle finding of having nocturnal hypoxemia can be associated with overall lung function. And obstructive sleep apnea. So this is characterized by upper airway obstruction, causing snoring, ineffective air exchange, or sleep disruption. So symptoms, I think we all know the classics, the person who snores, gasping for air, night sweats, poor concentration during the day, teeth grinding, restless sleep, low mood, sleepwalking, and just even insomnia. You find yourself waking up in the middle of the night and not sure why. Patients with CF have actually increased risk of sinonasal disease, nasal polyps, inflamed airway, sinus infections that increase nasal obstruction. So this can increase your risk for sleep apnea. We actually found that children with CF had increased prevalence of sleep apnea compared to adults because of their smaller airways. They tend to have larger tonsils, which are tissues in the back of the throat, and adenoids, which is tissue in the back of the nose. In that study they actually quoted earlier about nocturnal hypoxemia or low oxygen level at night, they actually found 32.3% of their patients had obstructive sleep apnea syndrome. So one of the things that I really always try to promote or talk about in my sleep visits across the board is promoting nasal breathing as opposed to mouth breathing, because this actually is very important for oral facial development in children. We know that there's association between oral breathing and the development of a more elongated lower face, which is actually associated with a narrower airway. And then even dental health, you have more cavities, more gum disease. I actually always thought this was like kind of a newer finding. I was surprised to find that literature way back, even as early as 1960, that they identified this association. So it's something that's been well known. I think that we should really address and just be aware of is, okay, if we see someone who is really struggling to breathe through their nose and tends to breathe through their mouth, addressing the nasal obstruction is important. And so the way to do that, there's, for chronic sinusitis, especially with patients with CF, consider aggressive medical management before surgery. Saline rinses, intranasal steroid sprays like your Flonase, your Nasacort, and of course antibiotics if needed. But for me, one of my favorite things to recommend to people are saline rinses because they're drug-free, they're well tolerated, and they're actually pretty effective. So let's say you try all that, but you have sleep apnea that requires a CPAP or bilevel. A lot of people ask, well, what is that? What does that mean? So CPAP stands for continuous positive airway pressure. So PAP therapy is just positive airway pressure therapy. This just uses air to keep airways open. It doesn't necessarily have oxygen. You can have oxygen go through it. It's not a ventilator. It's not breathing for you, but it can assist in your breathing. So the difference between CPAP and bilevel, or BiPAP is the term that you might hear, is that both of them still have air coming towards you, but with bilevel or BiPAP, you have one higher pressure when you're breathing in, and then a lower pressure when you're breathing out. So it's just a little bit easier to breathe out. So bilevel is particularly helpful in improving ventilation issues. So if you're having trouble with that oxygen carbon dioxide exchange, bilevel may be an option for you. Bilevel ST mode just means a bilevel or BiPAP that has a backup rate. There's auto CPAP and auto bilevel that you may hear about. These just mean that these are machines that can do some auto adjusting within what your doctor prescribes. This can be an option for some to improve in your comfort and adherence, but it depends on each patient. It's not right for every patient, but it can really be helpful. Lots of mask options. A lot of people go like, oh, I don't want to wear a scuba mask, or I remember my grandpa had one and it like covered his whole face. So I just wanted to tell people that there are a lot of new mask options out there. Here's one that just goes, these are called nasal pillows, just go into your nose. For those who actually need prolonged bilevel, let's say if your lung disease is kind of really progressing or you're doing an exacerbation, you need a bit more support. There's actually also new masks that allow you to be able to wear your glasses. You can wear throughout the day. They put less pressure on your face. So luckily there's been more and more options available. And I just mentioned this in case you hear about this, you can also do a whole bone structure surgery, which of course is not first, second, or third line, but there's some people who actually get their whole jaw structure changed. Something called a maxillomandibular advancement, which moves the lower jaw forward, opens up the airway a little bit more. You can do what's called a palatal expansion, which surgically you split the palate, expand the palate, and then actually also expands the nasal base as well. But these are just something to note. All right, insomnia. So this is something where I think a lot of us have experienced at some point in our life. So the definition of insomnia is actually quite simple. It's the inability to fall asleep or stay asleep, or you're just dissatisfied with your sleep. So often it's inadequately discussed and maybe underdiagnosed. Many people don't discuss with their doctor and they often self-treat. So sometimes we see patients will self-treat with alcohol or medications, over-the-counter medications, and if someone does bring it up to a doctor, sometimes they feel like they just get a med prescribed to them and they feel like they're not getting a lot of counseling. So chronic insomnia treatments. So first, I would say address the contributing factors for insomnia. So if we think insomnia is caused in part from pain, cough, abdominal discomfort, treat that, or anxiety. So I love, especially yesterday, we had some really great talks about embedding a psychiatrist into the CF team and doing ACT and doing different mental health practices. I thought that was fantastic. So finding ways to really address the anxiety and the mental health issues, I think, is really important. If you feel like you've addressed that and you're still having some insomnia, there's something called cognitive behavioral therapy for insomnia. This is a behavioral sleep specialist, uses a combination of behavioral interventions that can be proven to be effective and that can actually help reestablish your relationship with sleep. Like an example, this can be if you find that you, every time you go to your room, you feel like, oh, let's see if I fall asleep. That's probably not going to work. You now develop this relationship that when you go into your bedroom, you stress out about sleep. It's not your fault, but it's just what has happened because that's what's been the routine that you've experienced. So CBTI will help you figure out, well, how do I actually reset that relationship with my bed? How do I make it that when I get into my bed, I feel like, oh, this is where I sleep, this is where I relax. So that's that. I think CBTI is actually considered first line over any medication or Ambien. To explain a little bit like why CBTI works or just kind of why insomnia happens, I think it's important to understand a little bit of this two-process model for sleep regulation. This was described way back in 1982, and I think still holds a lot of the framework for what we do in sleep today. So you have something called a sleep drive. This is building every minute of your day. So as soon as you wake up, your body or your brain in a linear fashion is building up your desire to sleep. So that's what sleep drive stands for. It's also called homeostatic drive, all these other fancy names. Process S essentially means your desire to sleep. The theory is that adenosine accumulates in your brain. Adenosine is a byproduct of energy being expended. The more adenosine you have that builds up in your brain, the sleepy you are. Fun fact, caffeine is an adenosine blocker, which is why when you drink caffeine, you feel less sleepy. The other drive we have is called the wake drive or circadian drive. This is your desire to stay awake. So this actually, instead of the sleep drive keeps just building every minute that you're awake, this circadian drive has actually more of an oscillatory movement. So this is where your circadian clock actually kind of governs when you feel like you're at your most awake or your most alert and at your most sleepy. So if you think about it, if these things match up, you're able to sleep when you want to. So if your sleep drive is high and your wake drive is low, you're going to fall asleep. If you have the opposite, where your sleep drive is low and your wake drive is high, you stay awake. So you want to kind of have these things match up. All the things that affect these, your genetics can affect this. Just what you do during the day, your schedule. Zeitgebers is the term of anything that cues your circadian clock. This just means anything that can actually shift or move your circadian clock. Meaning, so light is actually the most powerful cue for your circadian clock. So that means as when you get light that shines on your face, that's actually one of the most powerful ways to shift it. So it's just to show your circadian clock is your natural internal rhythm that tells you when they want to wake up and go to sleep. So you see here, so you get the sunlight, it hits your eyeball, goes into your nerves, and then it goes through kind of to your suprachiasmatic nucleus, and then goes to your superior cervical ganglion, which then signals your pineal gland. So when you have light, it tells your pineal gland, don't secrete melatonin. We're not ready for that yet. But if your eyeball notices dark, it might say like, oh, hey, I think it's time for us to have some melatonin. So it'll tell your pineal gland to secrete melatonin. So light exposure can significantly adjust this. So some general sleep hygiene tips I tell everybody: try to make your bed your sanctuary if you can. So try not to do work, emails, fights, or watching even movies in your bed. That's the ideal. But I know a lot of times my patients with CF, especially when they're in the hospital, are kind of stuck on their beds, right? So a lot of them go like, well, this is a tough one for me. So if you have to be in bed, I say try to make your day and night different. So, when it's daytime, turn on the lights, open up the blinds, play some music, still do your grooming, get ready, brush your hair, try to do things that you can do to make your body realize, okay, it's daytime, let's make things a little bit different. Sit up in your bed if you can. So just try to make it a little bit different. At nighttime, incorporate a wind down routine. So 60 minutes before bed, start to calm down, avoid screens, dim the lights. Don't watch the clock at night. All of us have been guilty of doing this, where we keep looking to see how much more hours do I have to sleep. Oh no, it never calms us down. It only stresses us out. So I always tell people, don't watch the clock. Set your alarm when you have to wake up, and then just know if your alarm hasn't gone on yet, it's not time for you to wake up. If you're staying in bed and you realize that you're just thinking, or you're not able to fall asleep, I say get out of bed if you can. Do a relaxing activity until you're sleepy. Once sleepy, ideally get back into bed. Keep the same sleep-wake schedule at the same time each day if you can. And avoid hitting the snooze button when the alarm goes off. Actually make it that, okay, it's time for me to wake up. And if you can, get that bright light, get some natural light within 15 minutes of waking up. So sleep during this pandemic, I'm sure all of us have experienced just not only our life kind of being flipped over, but our sleep schedule being really, really messed up. So daytime and bedtime schedules have been all over the place. It's hard to track time without our typical anchors. For those who can't leave the house, don't go to school, aren't going to work, it's a little bit more fluid and harder to keep track. There's a temptation to oversleep. And there's staying indoors reduces light exposure. And as we've already talked about, light is important. Less exercise, less socializing, more screen time, more Netflix, right? And just increased stress and anxiety during this time. All have really kind of contributed to poor sleep during this pandemic. And I tell people, this is actually the time to prioritize sleep. Why? Because we've talked, it empowers your immune system, it increases your brain function, and it improves your mood if you get better sleep. So this is actually the time that we should be propping all these things up. So tips to promote sleep health during this time, I say, again, going back to maintain regular sleep-wake schedules, even if you have nowhere to go. Create some structure in your day. Wake up at the same time each morning, get the bright light. Consider grooming and getting dressed, even if you're not going anywhere. Just take that shower, take a bath. Block out time for exercising, socializing, video chatting with people, and have that same wind down routine 1 hour before bedtime. Quick word about melatonin. Honestly, melatonin itself can be an entire talk, but I just wanted to give a little bit about it. So generally, if you're thinking about how to use melatonin, like I said, your brain secretes it naturally, but sometimes you can use it you can take an external source, and that can help with your sleep. In general, if you have general insomnia where you want just something to help you fall asleep, I say take it 60 minutes before bedtime. Take generally 1 to 3 milligrams. More is not really necessarily more. You can buy up to 10 milligrams of melatonin. I don't think it actually offers benefit. In fact, you actually can be more groggy the next day. So I tell people 1 to 3 milligrams. If all you can find is 5, then okay. 60 minutes before bedtime. It's not going to knock you out. It's not going to cause you to just fall asleep, but it's supposed to make sleep more inviting. If you have something called delayed sleep phase syndrome, which again, whole nother talk, but let's say you have that circadian rhythm, you're trying to shift it a little bit earlier. You can actually take really low dose melatonin, 5 to 6 hours before bedtime. And this actually helps shift your circadian rhythm a little bit too. And I actually found just yesterday, I was at Trader Joe's last week. Trader Joe's has low dose melatonin. I'm really excited. So it was like only, I think, $3 a bottle. People ask about long-term safety. Well, it's not really well studied. We don't have that 10 or 20-year study. We just don't have it. The population where it is actually the most studied that I can see is, so a lot of my patients who have autism or ADHD tend to have relative melatonin deficiencies, like their brain doesn't secrete melatonin at the time that they really want. So a lot of those patients tend to really use melatonin a lot to help them stay on a cycle. The last study came back, I want to say in April, I can't remember the exact month of this year, and they had kids on 2 years of melatonin and actually did pretty well. They looked for side effects of withdrawal, they looked for dependency, they looked for even precocious puberty, which has been reported, and they didn't find any of that. So I tell people, you know, if you need it, you know, everything's a risk benefit, but I just say, ideally minimize use of any medications if possible. Other natural remedies to consider: valerian root. This can also relieve anxiety. Chamomile causes sleepiness and also reduces anxiety, and so does lavender. So those are things to think about. The question I often get: what about cannabinoids in sleep? So there's just so much that's still unknown. We just don't really know, to be honest. Results, data have been mixed, where the effects on sleep architecture and the treatment of various sleep disorders, you know, there's been some short-term data, and then there's some long-term data. To be honest, it's a little bit unclear in the sleep community. Really, are cannabinoids really helpful for sleep specifically? Of course, they can play a role in treatment of anxiety, nightmares, post-traumatic stress disorder, which can affect sleep as well. So it's a little bit mixed right now. I will say in children and teens, we do have studies where we know it changes the brain structure in teens who usually or who use cannabinoids on a regular basis. So generally for kids, we don't recommend it for sleep at all. And then people ask about naps. What about naps? Are they okay? Short naps are best. Naps greater than 30 minutes increase your risk for sleep inertia. Have you ever had that where you take a nap too long and then you feel like you have to, like, you wake up and you feel more tired than before you took your nap? So power naps are best. Early afternoon naps allow for increased sleep drive at night. So again, going back to that sleep architecture, if you're looking at this cycle, right? Ideally, if you're trying to see, you want to wake up from your nap from shallow sleep, right? So you still get some restorative sleep, but you're not going all the way into a full sleep cycle and getting that sleep inertia. So short naps are wonderful. Restless leg syndrome actually was mentioned yesterday in another talk, but this is a discomfort or odd feeling in the legs or arms that are improved with movement. It causes poor sleep, daytime sleepiness, associated with low central nervous system iron stores, and often just affected or treated effectively with just iron supplementation. So there's a case report that's well known of a 22-year-old woman who had CF and chronic hemoptysis. She had restless leg that prevented her from sleeping. So she got standard CF care. They were able to get the hemoptysis under better control, and she got some iron, and it resulted in resolution of her symptoms. So if you feel like you have kind of this like nagging feeling in your arms or legs and you're like, can't really describe what it is, it could be restless leg syndrome. Like I said, iron is usually the first treatment. Massage, compression stockings, those things. There's even this pad you can buy that vibrates and is supposed to kind of help your legs feel more comfortable. If none of those help, there are other medications. We start to get to gabapentin, good dopamine agonists. There are some patients who are on low dose opioids. So there's like steps to treating restless leg syndrome. Oftentimes in my pediatric practice, iron is usually sufficient. This is different from periodic limb movements. This is jerking of your arms and legs when the patient is asleep. So it can wake you up and annoy your bed partner. And this can be seen in a sleep study. They're not the same, but they actually often have the same cause, which is the low iron stores. It can be associated with all sorts of things: sleep apnea, chronic pain, narcolepsy, etc. Quick note about narcolepsy. So narcolepsy, this is a chronic neurologic condition characterized by excessive daytime sleepiness, sleep paralysis, fragmented sleep. I didn't put it here, but patients also experience more hallucinations when they're falling asleep and waking up, things that they know aren't there, but that they can see. This is generally associated with a decreased or absent hypocretin or orexin protein in the central and cerebrospinal fluid, which causes a disruption in your sleep-wake cycles. And essentially, like REM sleep or dream sleep kind of interjects at the wrong time, just kind of comes all over the place. There's not a great sleep architecture that's noted. So one of the things that we see is something called cataplexy. So this is a partial or total loss of muscle control, often triggered by laughter, unfortunately, where then a patient will have muscle paralysis and almost like fall to the ground and actually just kind of lose their muscle tone. This is, again, going back to what a rapid eye movement sleep is, active mind, paralyzed body. So that's what we see, and we can see in narcolepsy. Diagnosis is where it's really good to go to a sleep doctor or a neurologist to get this diagnosed. It requires a sleep study, a special daytime nap study, and the treatments can be stimulants, anti-cataplectic medications such as even SSRIs, which are like your Prozacs. Another medication is sodium oxybate or strategic napping. So when to consider a sleep evaluation as a CF patient. You experience daytime sleepiness or brain fog, you have trouble falling asleep or staying asleep, your FEV1 is less than 65%, and that's because of all the things I've talked about. You're worried about hypoxemia, the low oxygen, high carbon dioxide. You have morning headaches, which could be a sign of high carbon dioxide. You snore, could be a sign of sleep apnea. You have a cardiac condition or pulmonary hypertension, because sleep apnea can actually make these things worse. You have nightly leg discomfort, or you just want to ensure your health is optimized. And a sleep evaluation doesn't always mean necessarily sleep study, but just a discussion with your doctor. So my take-home points, poor sleep quality can affect all aspects of health. Therefore, sleep health should be considered part of the care plan for every patient with CF. Sleep is a vulnerable time from a pulmonary function standpoint. Multiple factors may contribute to sleep: coughing, pain, medications, mood disorders. Have a low threshold for sleep testing. Incorporate healthy sleep habits into your everyday, even during the pandemic. I know I don't do this perfectly, but I try as much as I can. And consider CBTI for insomnia over medications. I think that's it.